All right, welcome everybody. My name is Shadi Reyes. I'm from Detroit Medical Center. Thank you for joining our DMC Medical Group Heart to Heart webinar series. We come to you every third Thursday of the month at 7 p.m. Eastern Time. Thanks for all the people who registered and who's joining us tonight. The topic for this for this month is the role of SGLT-2 inhibitor in cardiovascular disease. Our guest speaker is Dr. Aziz Alkatib. He is an interventional cardiologist as well as cardiologist at Huron Valley Detroit Medical Center. Before we jump to the topic, I just want to introduce our group. We are based at the Detroit Medical Center in Detroit. Also, we have our cardiovascular service at Huron Valley in Commerce Township with Dr. Mokano and Dr. Alkatib. Thank you again for joining us. Dr. Alkatib will be starting the presentation soon. Please use the chat box for any question. Again, as we know, the SGLT-2 inhibitor are diabetic medication, but it has been gaining a lot of attention for patients with heart failure, with reduced ejection fraction, for primary care, as well as for cardiologists. With no further ado, Dr. Alkatib, please share your slides.
Well, thank you very much, Dr. Reyes. Thanks, Dr. Zaire. Happy to be with you. Thanks for joining us this evening. And today I will be discussing the role of SGLT-2 inhibitors in the management of cardiovascular disease. As Dr. Reyes alluded to, this is sort of a hot topic, and there's a lot of exciting information to go over. And so I hope today to convey an understanding of the mechanism of action of the sodium glucose cotransporter protein, and how that relates to clinical meaningful benefit. We'll review the latest clinical evidence and trial data regarding the use of the SGLT-2 inhibitors, specifically for treating patients with cardiovascular disease and heart failure. We're going to examine some of the barriers to implementation of guideline-directed therapy and hope to provide some practical guidance, tips and tricks, so to speak, on the use of these medications to manage heart failure and cardiovascular disease in general. Okay, so what are some of the highlights of the class? We know that patients with diabetes have high residual risk for the development of cardiovascular complications, and particularly for advanced diabetic kidney disease progression. These medications have consistently shown reduction in the risk of hospitalization for heart failure, as well as protection from diabetic kidney disease progression. And so when we select antihyperglycemic agents, we want to take into account several factors, certainly the presence of cardiovascular disease, risks for cardiovascular disease, heart failure, and certainly renal complications. So the prevalence of cardiovascular and metabolic diseases in the United States is quite profound. We can see a staggering number of diabetic patients in this country. This goes hand in hand with the current obesity epidemic. We know the atherosclerotic and macrovascular complications associated with diabetes. We can see here that a large number of diabetics have established cardiovascular disease, but in particular, heart failure and specifically heart failure hospitalization is probably one of the more common and most serious complications of diabetes. You can see that the number is about split between the reduced ejection fraction and preserved ejection fraction heart failure patients. And so much has been written about how diabetes directly affects the myocardium in this concept of diabetic cardiomyopathy. These are the currently approved SGLT-2 inhibitors on the US market. They include DAPA-Gliflozin, brand name Farxiga, EMPA-Gliflozin or Jardiance, and Canagliflozin or Invokana. They are the gliflozin drugs. And there is some commonality here as far as the indications go. They include renal protection, reduction of cardiovascular death, and a reduction of heart failure hospitalization. And yes, they are also indicated to lower blood glucose in diabetics. But when you take that in isolation, that's probably one of the, a lesser impactful benefit, as we'll learn. There are others, erdagliflozin and sotagliflozin is the newest to the market. It's currently, the study has been released and it's currently pending FDA review. As far as the pharmacology goes, in general, they are equivalent in terms of the pharmacokinetics, bioavailability, once daily oral dosing, the half-life. They're by and large equivalent. And bear with me now, this is a cardiologist's review of renal physiology. Over here on the left is a highly oversimplified schematic, but you have filtration that occurs in the glomerulus, and so the glucose is filtered. Downstream, the glucose is reabsorbed back to the circulation, and what's left is what the body doesn't need is secreted and eventually excreted in the urine. And when we and so under normal physiologic conditions, glucose is completely reabsorbed and is not excreted in the urine. When we talk about the SGLT-2 protein, that occurs in the outer cortex, primarily in the proximal convoluted tubule. And we see here that the SGLT-2 transporter protein, again, located along the proximal tubule, and that is responsible for over 90% of glucose reabsorption, again, through this transporter protein in the proximal tubule. And so when you then inhibit this transporter protein with these drugs, at therapeutic doses, you'll get approximately 60 to up to 100 grams of glucose that is then excreted in the urine. And so these drugs directly lead to removal of glucose from the systemic circulation, which is then excreted into the urine. This, as you can imagine, would cause an osmotic diuretic effect. Through, again, osmosis, you're going to pull in sodium and water. And so there is a diuresis. You can start to see how that would be beneficial to heart failure patients. A similar circumstances occur with a low carbohydrate diet or a fasted diet where you have increased ketone production that doesn't get reabsorbed and leads to an osmotic diuresis. So these patients, when they start these diets, will oftentimes have a very brisk and robust weight loss due to diuretic effect right off the bat. Additionally, there are multiple complex and secondary effects that likely contribute to the benefit. We'll explore that a little bit later on, but this is the basic mechanism. And so what happens to the hemoglobin A1C? This is from one of the empagliflozin trials, and that you can see here compared to placebo, there's an immediate effect on hemoglobin A1C lowering. Note, however, that over time, the A1C tends to creep back up, but at about the 12-month mark, you'll get a 0.5 to 0.9% reduction in hemoglobin A1C, which is considered relatively mild to modest. There is associated weight loss. Again, there's a diuretic effect, and you are removing glucose and essentially calories from the systemic circulation. And so that leads to about a 2 kilogram on average weight loss. Additionally, there's reduction in systolic blood pressure, which is very mild, but it is apparent in these drugs. So now, what are the effects on clinical parameters in diabetics stratified by CKD stage? And what you'll notice here is that with advancing renal impairment, there is a diminished effect on glucose lowering. So when you reach stages 3 and later, there's really a neutral effect on blood sugar lowering. But notice, however, that the cardiovascular benefits are preserved. And so this speaks to a mechanism likely that goes beyond glucose control in terms of the overall cardiovascular benefit. Note here that when you start these medications, there is a temporary reduction in the GFR. I'll discuss more of that later. But know that the SGLT-2 inhibitors have renal protective benefits and are in fact indicated to prevent CKD progression. Another nice effect is that there is a lowering of uric acid levels. You'll remember that with loop diuretics, which are commonly prescribed in heart failure patients, that can lead to hyperuricemia and over time potentiate gout attacks. The SGLT-2 inhibitors avoid that potential complication. There's an interesting history behind the diabetic drugs and cardiovascular disease. In 2008, the FDA mandated that all new diabetic agents be methodically examined for their CV risk in all future trials. And this stems from what we know about the excess burden of cardiovascular disease and type 2 diabetes, and more specifically, concerns raised from a meta-analysis that looked at increased risk with some of the drugs, in particular rosiglitazone. There was a signal for increased CV risk, which obviously would be detrimental. And so then the FDA put out this mandate. And so this led to more cardiovascular outcome trials with glucose lowering drugs, and has started to redefine how we manage diabetes in light of cardiovascular disease. And so we started to see this paradigm shift. In other words, the glucose control in and of itself is really not enough. We have to adopt a more broader strategy to include CV risk reduction. And so you'll remember the days of intensive versus non-intensive glucose control, hemoglobin A1C targets, what's the right level to achieve. That is a completely outdated paradigm. Right now, it's all about CV risk, because after all, diabetics die from cardiovascular complications, and that must be taken into account. And so we'll switch gears here and spend considerable time talking about the relevant CV outcome trial data with the SGLT-2 inhibitors, and I'll hopefully make a case for a class effect. This is a timeline of the major trials that have studied the SGLT-2 inhibitors, starting in 2015 with the EMPA-REG outcome trial that looked at diabetics, all the way up to the EMPEROR-Preserved, which looked at empagliflozin in heart failure with preserved ejection fraction patients. There are other studies, many studies ongoing that are studying various subgroups. And I suspect, again, that the coming years will place a lot of emphasis on this class of drugs. Some have drawn analogies with the statin drugs and how they revolutionized how we manage cardiovascular disease. So let's get right to it with the initial trial, the EMPA-REG outcome trial published in 2015. This included 7,000 patients with type 2 diabetes and established cardiovascular disease. So they've had established coronary disease, stroke, etc. They were randomized to either placebo or a varying dose of empagliflozin. Their cardiovascular risk and disease was treated according to standard of care. So these patients were on aspirin, statin, beta blockers, etc., all according to the standard of care. The primary outcome studied here was death from cardiovascular cause, non-fatal MI, and non-fatal stroke, with a median observation time of just over 3 years. And what was seen is that empagliflozin was significantly superior for the reduction of the primary endpoint. Again, the composite of CV death, MI, and stroke, empagliflozin showed superiority compared to placebo. Looking at CV death and all-cause death, also both showed superiority with empagliflozin. And note that there was early separation of the curves for both. I'll more on that later, but this was a highly positive trial. Fast forward now 2 years later, where the Canvas trial was published. This was using canagliflozin. These two trials were very similar in terms of trial design. The Canvas trial included diabetics with established cardiovascular disease, but also included patients with high risk for cardiovascular disease. This trial had about 10,000 patients versus 7,000 with the EMPA-REG. But as you can see, there was a positive effect for the composite outcome and borderline for death from cardiovascular causes. Although you could argue that the magnitude of the result is not as robust, but it is a positive trial nonetheless. Back to the EMPA-REG outcome trial, an interesting and profound finding was that there was a significant protection from hospitalization for heart failure. Okay, now remember, this was not a heart failure study per se. A low number of patients reported a history of heart failure at baseline, but nonetheless, there was a risk reduction in patients whether or not they had any history of heart failure at baseline. They were protected from hospitalization for heart failure. And again, the same finding in the Canvas trial with a reduction in hospitalization for heart failure. So to summarize, we see some profound positive effects here from the EMPA-REG outcome trial with a 38% relative risk reduction for cardiovascular death, 35% risk reduction of hospitalization for heart failure, and a 34% relative risk reduction of the composite of the two. This now led to dapagliflozin being studied. This is the largest of the trials to date, looking at diabetic patients. It included 17,000 patients, about as many as the prior two combined. These patients had risk factors for cardiovascular disease or established CV disease. They were randomly assigned to DAPA versus placebo, and the outcomes studied you can see here. A good long median follow-up time of just over 4 years. And for the endpoint of cardiovascular death or hospitalization for heart failure, it was statistically in favor of dapagliflozin. The MACE outcome, however, did not meet statistical significance, but the finding was borderline. Looking at the data another way, again, cardiovascular death or hospitalization to the left here was positive, MACE was borderline, but what I wanted to highlight here was the renal protection that you get with these medications. There was a highly significant finding of protection from advancing stages of renal disease or death from renal cause. And so naturally, the next step is to meta-analyze the data. And when they pooled results from all of the major trials for the outcome of CV death, the composite was positive in favor of treatment, driven primarily by the highly significant finding from the EMPA-REG outcome trial. And so there does appear to be a protection from CV death. Now, when you look at hospitalization for heart failure, across the board, all of these trials showed a significant protection from heart failure hospitalization. And so now you're starting to see a class effect. So To summarize these medications in diabetics, we know that the SGLT-2 inhibitors favorably affects the CV outcomes in patients with diabetes. There are robust and consistent associations with reduction in hospitalization for heart failure, and that appears to be independent of baseline cardiovascular risk or renal function. There is some heterogeneity in the product labeling, with empagliflozin highlighting the reduced risk of CV death, canagliflozin reduced risk of MACE, and for dapagliflozin really highlighting that reduced risk of heart failure hospitalization. It is, however, generally accepted that the SGLT-2 inhibitors have a class effect. In other words, they all work in a similar mechanism to have to produce similar protective benefits in the outcomes. The differences in the magnitude of outcome and the meeting significance or not is more likely due to the differences in trial design than anything else. And so, up to this point, we've studied the diabetic patients and the outcomes. What about heart failure patients? And so that is what the DAPA-HF trial was designed to study. This was a study that included 4,700 patients with heart failure, defined as an ejection fraction less than or equal to 40% with class 2 to 4 symptoms. These patients were on standard therapy for heart failure, including Entresto, beta blockers, the MRAs. They were now randomly assigned to dapagliflozin 10 milligrams versus placebo. And the primary outcome studied here was worsening heart failure or cardiovascular death, with a median follow-up time of just over 18 months. So note again that the population studied here were heart failure patients. These were not necessarily diabetic patients. And in fact, roughly just over half of the patients in this trial did not have diabetes. And what was seen is that the risk of the primary outcome was significantly lower for the dapagliflozin group versus placebo, demonstrating a 26% relative risk reduction for the composite of worsening heart failure or cardiovascular death, with a number needed to treat of 21. Again, keep in mind that this was on top of standard of care therapies. Looking at the individual components across the board, you see whether it's hospitalization or urgent visit for heart failure, and yes, even CV death, all were statistically significant in favor of dapagliflozin. Now, did it matter whether they were a diabetic at baseline or not? And as you can see, the benefits were similar in patients with and without diabetes, which again suggests that the mechanism of benefit here were completely independent of glycemic control. So heart failure patients benefit whether or not they are diabetics. The EMPA-REG reduced trial then came out, very similar in trial design to the DAPA-HF in that they studied heart failure patients. The inclusion criteria, again, did not specify diabetic patients, and roughly half did not have diabetes. And you can see here for both the primary outcome and the reduction in heart failure hospitalization, this was a highly significant positive trial. And so now to summarize the heart failure studies, irrespective of the presence or absence of type 2 diabetes, there's a significant reduction in heart failure hospitalizations and cardiovascular mortality observed both with dapagliflozin and empagliflozin, demonstrating a clear benefit for patients with heart failure. And last but not least, the EMPA-REG Preserved trial. This was just published last month. It included just under 6,000 patients now with heart failure and preserved ejection fraction. These patients had an ejection fraction over 40%. Now, this is somewhat controversial in terms of where do you draw the line between preserved and reduced ejection fraction. But regardless, this is the definition that was used. They were randomly assigned to empagliflozin versus placebo. And you can see here that for the primary outcome of cardiovascular death or hospitalization for heart failure, this was a positive trial. So now you see this was the first randomized control study to look at the impact of SGLT-2 inhibitors on the HErEF patients. And it just provides further data to support the expanding role of the SGLT-2 inhibitors for management of heart failure. This is important because, as you know, there are limited therapies for the management of HErEF. These patients can be very challenging to treat, and this adds another tool to help these patients stay out of the hospital and prevent decompensation. And so with this data, the ACC in 2017 held a roundtable collaboration between cardiologists, primary care doctors, endocrinologists, and the goal was to provide practical guidance, support, and tools for clinicians to understand how to manage these patients better with these new drugs. And they recognize that there's a need to shift from glycemic control alone to reducing cardiovascular risk and cardiovascular death. They also recognize that cardiovascular clinicians have an important role in prescribing these novel anti-diabetic agents. The European Society of Cardiology recently updated their guidelines to include both dapagliflozin or empagliflozin, which is now recommended for patients with heart failure with reduced ejection fraction to reduce the risk of heart failure, hospitalization, and death, class 1 level A evidence, right along there with Entresto, the beta blockers, and the MRAs. And so the experts have touted this so-called quadruple therapy for heart failure, the HErEF patients. As we know, the ACE, ARB, or preferably ARNI, Entresto is recommended in addition to a beta blocker and MRA. And now they are recommending the addition of an SGLT-2 inhibitor. And what they calculated was that this combination adds on average 6 years of overall survival in a hypothetical 55-year-old HErEF patient, an additional 8 years free from cardiovascular death or first hospitalization for heart failure. And so what are some of the benefits that we're seeing here? What explains these positive outcomes? There are theories, starting with improved hemodynamics. Again, because of the diuretic effect, you have reduction in preload, the reduction in systolic blood pressure to reduce the afterload. But again, that doesn't really account for all the benefit because thiazide diuretics, loop diuretics also have a similar mechanism, but certainly don't have the benefit in terms of heart failure protection that we see here. And so in theory, they have looked at improved cardiac metabolism through increased ketone production. In other words, the myocardium becomes more energy efficient, if you will. Through inhibition of the sodium-hydrogen exchange, there are reductions in hypertrophy, systolic dysfunction, remodeling. Additionally, they have found a reduction in necrosis or cardiac fibrosis and potentially a reduced risk of arrhythmia and sudden cardiac death. And so there are these complex secondary or pleiotropic effects that occur at the cellular or metabolic level that are likely contributing to the beneficial effect. Again, I draw the analogy between the statin drugs in terms of their secondary effects. We know that individuals who have longstanding diabetes, even if they have healthy coronary arteries, that doesn't necessarily mean that their ventricles or ventricle mechanics are normal. And so they can be predisposed to developing heart failure and decompensation from heart failure, even in the absence of macrovascular disease. I want to highlight this post hoc analysis of the EMPA-REG outcome trial, where they looked at the timing of the treatment effect. So in other words, when was the first time that the showed a statistically significant benefit? And so for the outcome of CV death, you can see here that at day 59, there was a statistically significant benefit. For first heart failure hospitalization, that occurred at day 17. So not only do these drugs show a profound, significant benefit, it happens expeditiously within days to weeks of treatment initiation. And again, I've said this before, but this really speaks to a mechanism that is independent of glucose lowering and not related to any mitigation of atherosclerosis progression, right? Because this is too fast to have any effect on atherosclerosis. And so this was just published 2 days ago, but experts have called for in-hospital initiation of the SGLT-2 inhibitors, specifically for heart failure patients, because of these profound and expeditious clinical benefits that we see. And they use this to make their argument. And this shows that for patients who are prescribed these heart failure drugs at time of hospital discharge, at follow-up, their adherence is much, much higher than it would be for patients who were deferred starting these medications to a later time. And so that they're saying that get these drugs started right away, even during hospitalization or hospital discharge. So the SGLT-2 inhibitors suffer from therapeutic hesitancy. What is that? Well, it's defined as the failure to initiate treatment, even though it is evidence-based and guideline recommended. And so they have found that only 5% of eligible patients are treated with SGLT-2 inhibitors in clinical practice. Furthermore, less than 5% of the current prescriptions are initiated by cardiologists. And so what are the reasons behind the therapeutic hesitancy? And I'll freely admit I fell into one or more of these categories myself as a cardiovascular clinician. But wanting to defer the SGLT-2 initiation to a diabetes specialist due to fear of encroaching on their domain. Right? There's difficulty keeping up with the evolving data, and it is evolving rapidly. The trial data that I showed was really just a small fraction of the available data that's out there. Lack of familiarity with the diabetic agents that have demonstrated CV benefits. Concerns about side effects. Am I going to drop the blood sugar? Is this going to interact with their current medications? Am I going to harm the patient? Polypharmacy, burdensome medication regimens. Patients generally don't want to take more medicines, and they Google their medications and look for any reason not to take them. That's a major challenge we all face. In general, we lack focus on CV death prevention, and certainly accessibility issues, cost, etc., can pose a challenge. So I'd like to provide some practical guidance here for the use of the SGLT-2 inhibitors. Really, the only a few contraindications. Obviously, if you're allergic, don't take it. Severe renal impairment, if their GFR is less than 20, or if they're end-stage renal disease, do not use the SGLT-2 inhibitors. They have been studied in very low, in the 20 to 30 GFR range, but otherwise less than that, do not use. Because, again, of the diuretic effect and the slight reduction in systolic blood pressure, if at baseline they're orthostatic, that's a patient you would want to avoid. Type 1 diabetes is not an absolute contraindication, but there is a very, very small risk of DKA, which should be taken into account. My advice would be to seek advice from a specialist. Because of the glucose excreted in the urine, that creates an environment which may predispose to genital mycotic infections, candidal vaginitis, for example. These generally respond well to treatment with oral, topical antifungals or occasionally oral fluconazole. But patients should be aware and asked to monitor signs and symptoms. There is no increased risk of urinary tract infections that was studied in any of the major trials. The risk of hypoglycemia is very, very low. Okay, remember that the mechanism here is to filter out an excess load of glucose. There is no increase in insulin secretion, so the risk of hypoglycemia is low. Keep in mind, however, that you may wish to discontinue the sulfonylureas and possibly lower the insulin dose when starting these medications in order to mitigate the potential for hypoglycemia. Again, because of the diuretic effect, you want to understand what their fluid status is and possibly adjust other diuretics as needed. The thiazide or loop diuretics potentially could predispose to excessive diuresis, particularly in the elderly or frail. So that's something to keep in mind for. The sick day adjustment refers to instances where you may want to hold someone's diuretic if they are suffering from gastrointestinal problems, poor oral intake, fluid loss, any instance where you'd ask a patient to hold their diuretic, you may want to hold their SGLT-2 inhibitor as well. Check renal function when starting and monitor, but know that the trial data have not shown any increased risk of hypotension or AKI due to overdiuresis or pre-renal failure, etc. So again, when you start these medications, there will be a small bump in the creatinine. Okay, that is expected, and it's completely reversible when you stop the drug, but it should not lead to premature discontinuation of the drug, because as you'll see that over time, again, these have renoprotective properties. And so it decreases the slope of renal decline, renal function decline when compared to placebo. And so again, there's a renoprotective effect, and these are indicated to prevent CKD progression. So just because you see that, you don't have to stop the drug. Finally, this schematic describes a sort of a practical approach that we and others as clinicians can use to prescribe these drugs. Step one, obviously you want to identify the appropriate patient, and those would be any diabetic with cardiovascular disease, any patient that's had a stent before and who's a diabetic. Just think of all those patients that you see or who are at high risk. Heart failure patients, especially those who are at risk of decompensation. Perhaps they were just hospitalized for heart failure exacerbation and you're seeing them in follow-up. That would be an ideal candidate. Next, you want to select your drug. And again, there is a class effect here. And so my advice is to just choose one and get comfortable with it. You want to know what their baseline GFR is. And remember that there is going to be an initial drop in the GFR. That's temporary, expected, and is not a reason to stop the drug. You want to know and understand what their volume status is at baseline, and do they need a little extra diuretic or not? And keep that in mind when adjusting their diuretic regimen. You want to counsel the patient on the risk of the genital mycotic infections and what to look out for, and be aware of the potential for fluid loss. Anytime there are issues, you're encouraged to communicate with the primary care and diabetes specialists as needed. And finally, just continue with your routine serial assessments. The beauty of these is that for the CV protection, there really is no need to titrate the dose. You just get them on the target dose and keep them there, and they will derive the benefit. And so to wrap things up, the past decade has seen many robust cardiovascular outcome trials conducted in diabetic patients with cardiovascular disease and risk factors. Several of these trials have reaffirmed the safety and efficacy of these medications for, again, patients with atherosclerosis and diabetics. Additionally, heart failure patients or CKD patients, irrespective of the diabetes status. And again, we've seen this paradigm shift away from glucose management alone to one which accounts for cardiovascular disease, heart failure, and renal complications. All those need to be taken into consideration. Finally, the challenge remains to bridge the gap between scientific evidence and clinical practice, and likely requires a multifaceted, multidisciplinary approach where we kind of collectively work to identify these patients and get them on appropriate therapy. And with that, I'll thank you all for your attention, and I'd be happy to answer any questions if there are.
Thank you so much, Dr. Alkatib, for a phenomenal presentation, and thanks for putting your contact information there for any question. I have a few questions coming from the audience. Dr. Zair, any comments before we start going through the rest, the questions, sorry?
You're on mute, Dr. Zair.
I appreciate it, Aziz. I learned a lot. I appreciate it very much, Dr. Alkatib. From a surgeon's perspective, we look at this and I say, where's the downside? We're looking at 48 months. We're looking at a 35% reduction of cardiovascular death. It works in patients with reduced ejection fractions. It works in patients with preserved ejection fractions and diastolic dysfunction. It reduces the burden of insulin. Is there a downside to this class of drugs, or should this be a pay-for-play Blue Cross Blue Shield metric in these patients?
No, absolutely, absolutely. I see no downside. This really should become standard of care, especially for those patients at risk. There's, again, I talked about the therapeutic hesitancy. I think a lot of it is just lack of familiarity. Cardiologists, I was one of these. When this was introduced, I said, listen, this is a diabetic drug. I'm not going to, I'm going to stay in my lane. I'm not going to prescribe these. I don't feel comfortable with it. And part of that was, unfortunate, in my opinion, marketing error. These maybe should not have been marketed as diabetic drugs. They should have been marketed as cardiovascular, metabolic drugs, or heart failure drugs, or even rebranded completely. But regardless, as this gains momentum, I think we'll start to see a push and a broader use of these drugs because of the benefits. And again, I see no downside, really.
Is there's so many of them, is that because every drug company has one? Or do you perceive that there are some subtle differences that clinicians will figure out which one they should use in a specific patient?
I don't think there are major differences. I think it's clear that there's a class effect. You can nitpick. I mean, it's the same thing with, beta blockers, ACE inhibitors. They generally all work, but maybe one trial favors one over the other in certain situations. The empagliflozin really highlights the atherosclerotic cardiovascular benefit. The DAPA really highlights the heart failure. But again, I think the more these are studied, the more you're going to see a consistent, significant benefit. And, again, as I said before, pick one and get comfortable with it. And, I think the patient is going to benefit.
How about expense?
Yeah. So, I mean, these are new drugs, they're branded. And so cost is an issue. But, again, this is where, the commercial and, the drug companies need to step up and improve the accessibility. Again,
Thank you,
heart
Shadi.
failure hospitalization is very, very expensive. And so any drug that shows reduction,
Of course,
you have to support that.
especially if the reduction is at 17 days for the first hospitalization, you start to see a crossover. Do you see a reduction in hemoglobin A1Cs?
Yeah, you do. It's a mild effect. You get about maybe 0.5% up to just under 1% of reduction at 12 months. It does start to creep up over time. I think as a diabetic or glucose lowering drug, probably not the best. But in terms of the cardiovascular benefit, that's really where the profound effect is.
One of the question came is any complication with long-term use of Jardians in type 2 diabetics?
With long-term use, with Jardians specifically, no, none that I'm aware of. Some of the Canagliflozin or Invokana, there was a suggestion of increased risk of peripheral amputation that was raised in one of the trials. When they compared to placebo, there was a higher risk of toe amputation and possibly even osteoporotic fractures. But when they studied this further, that didn't pan out, and so it was sort of dropped from the warning. But other than that, long-term negative effects, none that I'm aware of.
Okay, and another question coming is there a significant hypokalemia or arrhythmia caused by the initiation of this medication?
No.
I didn't see any, but just trying to.
Nope.
Yep.
No, that was not, no, that wasn't an issue. There's no QT prolongation. There's no real effect on any of the electrolyte imbalances, etc. Interestingly, though, it raises the hematocrit slightly, and that's from a contraction phenomenon.
Now, you showed a lot of several meta-analysis. Every meta-analysis virtually was on the left side of the line.
Yes.
Are any of the studies excluded, or is this excluding them all?
No.
Are all the studies positive?
All up to the date, of that publication. Yeah, there aren't any outliers.
No negative studies.
No there were some that were, just missed the mark or borderline, but certainly none of them showed a harm.
One good question came is there's a challenge especially with elderly patients
Yes.
in terms of titration or compliance with medication. So the question, would you advise starting slow at 5 and build it up to 10, or start at 10?
Yeah, so for dapagliflozin in particular, yeah, they do recommend starting at 5. Now, the hemodynamic difference between 5 and 10, I'm not sure is that significant. But yes, if you have an elderly, frail patient, maybe they're sensitive, maybe they're borderline blood pressure, you certainly could start at 5 and see how they tolerate that before getting to the target dose of 10. Yep.
And also in the trial, that only small number of patients were started at 10 and decreased to 5, sorry. But majority were on 10, as you mentioned earlier.
That's right. That's right. That's considered the target dose.
Correct. Canagliflozin was associated with almost a 2-fold increased risk for lower limb amputation compared to placebo and Canvas arm.
That's right.
Empagliflozin has not shown an increased risk of lower limb ischemia or amputation. What was the later data that refuted this that you mentioned?
Yeah, so a later trial that looked at canagliflozin did not show that finding, and so it was determined to be due to a chance finding because none of the other trials with the SGLT-2 inhibitors showed a similar finding. It was really just the Canvas that had that finding, but the subsequent trials with canagliflozin that looked at renal outcomes did not show that finding. So it was attributed to a chance finding.
So just for the audience, primary care or cardiologist, just give us the bottom line. If I see somebody with ejection fraction 40 or 30% in the clinic, with or without diabetes? What's your approach?
So yeah, great question. This is sort of where the art of medicine comes into play, right? We know that there are these medications, there are several of them now that have benefit. What do you start first? Do you increase the dose of one before going to the other? And it's not a simple, straightforward answer. Again, this is art of medicine here at play, but there are many factors. How low is the ejection fraction? What's their baseline renal function? Blood pressure? How symptomatic are they? My approach, I get the patient on Entresto if I can, or if I can't get them on Entresto, why? That's my first choice. And then, low dose beta blocker and get them on spironolactone as tolerate. And then certainly my goal is to get them on all four with the four pillars that I showed, and monitor them and titrate them as needed. The beauty of the SGLT-2 inhibitors, again, you're not going to get a blood pressure effect as you would with, say, Entresto. And so that, a lot of times we're limited by, systolic blood pressure. So that's one of the advantages here of starting the SGLT-2 inhibitor. So you could do SGLT-2, Entresto plus SGLT-2 inhibitor, and then see what blood pressure you have left, work with a low dose beta blocker and a mineralocorticoid receptor agonist as well.
One of the slides you showed that got my attention is the European guidelines, where they show it's SGLT2 inhibitor are 1A compared to
Yes.
Entresto is even lower.
Yeah, exactly. So
I mean, like even ahead of the Entresto.
Exactly, because it's trial after trial with drug after drug, all you saw. I mean, with the heart failure hospitalization reduction. And when patients are admitted to the hospital with heart failure, it's not just burdensome from an economic standpoint, but those patients tend to do worse and worse and worse each time they're hospitalized, eventually where they're closer and closer to a mortality. And so there is a great benefit to keeping patients out of the hospital. And when you see this drug time after time with positive data on heart failure hospitalization, that's a strong argument in favor of the use.
Is there an issue at all with insurance's approval of starting this med, or are most insurances on board?
In my experience, it's somewhat mixed. Most insurances are on board. Occasionally, you'll get some pushback. Reach out to your representative for assistance. But by and large, they are, covered for most patients with perhaps some extra paperwork, but hopefully over time, it's not a big of an issue.
Yeah, to comment on this commercial, Dr. Zair, is majority of the commercial are covered. There is a coupon and 30-day trial comes also to the clinic. We have coupons for it. And Medicare. Medicaid is becoming the challenge, but usually we prescribe for patient with some coupons. Last question, and then we'll close, is EMPA-REG. What is your practice for preserved ejection fraction? I know the guideline did not incorporate this, but the trial was favorable.
Correct, right. And it's too new to be incorporated into any clinical, guideline at this point. But the results are, very significant, and those patients are particularly hard to treat. Now, Entresto has shown similar benefits, as you know, Shadi, in the HFpEF patients. Spironolactone as well. So until now, those are the drugs I have reached for the HFpEF patients that are frequently decompensated. But now again, with this new data, eventually we're going to get more and more trial data, and at some point I would imagine this would be the indication would expand to now include heart failure with preserved ejection fraction patients. So I have not yet incorporated that, but based on the EMPA preserved, it certainly would be reasonable to, especially since the options are limited.
Absolutely. Well, thank Dr. Alkatib, thanks so much. I think we covered all the questions. It was very engaging presentation. As you said, it's a very hot topic now. especially in the patient with no diabetes but heart failure. It's a topic for cardiologists, primary care physician, and the endocrine as well. Please, I would like to thank Dr. Alkatib for his presentation and for your engagement. I would like to put a plug for our next month speaker is Dr. Mendel. He's also from DMC Medical Group, going to talk about minimally invasive robotic valve and antiarrhythmic surgeries. He comes to us from St. Grace Hospital. And also remember that all these lectures are stored on a YouTube channel for DMC Medical Group. Please subscribe and like the page, and you can reference, this will be ready for you within a week on our library. Again, for any DMC transfer, for any cardiovascular care at main campus or other campuses, please call this number. For any cardiac or cardiothoracic or cardiac surgery referrals, ECMOs, and urgent needs, 313-578-6767. Again, thanks, Dr. Zer, for moderating. Dr. Alkatib, thanks again for phenomenal presentation. And for the audience, thank you for staying with us this late on this cold, breezy, and snowy day at Detroit. And have a good evening. I hope you have enjoyed this DMC Medical Group video. To find more content, webinars, and physician videos, visit dmcmedicalgroup.com.